For Patrick test, subject lies supine on the table and is then instructed to flex, abduct, and externally rotate the involved leg until the foot rests on top of the knee of the non-involved lower extremity. The examiner then slowly abducts the involved lower extremity while stabilizing the opposite side of the pelvis, bringing the knee closer toward the table. Positive finding is revealed when the involved lower extremity does not abduct below the level of the non-involved lower extremity. This may be indicative of iliopsoas, sacroiliac, or even hip joint abnormalities. For 90-90 straight leg raise, patient lies supine, stabilizing both hips at 90 degrees of flexion with both hands. Both knees are bent in a relaxed position while the subject is instructed to actively extend one knee at a time, as much as possible. If the knee is flexed greater than 20 degrees, the hamstrings are considered tight. Always test bilaterally.
For the Ober's test, the patient lies on her side with her hips and knees extended so that the test leg is superior to the non-test leg. The examiner stands with his proximal hand stabilizing the pelvis and the distal hand supporting the lower leg. With the pelvis stabilized to prevent rolling, abduct and extend the test hip in order to position the IT band behind the greater trochanter, then allow the leg to slowly lower, adducting. The inability of the leg to adduct and touch the table is indicative of IT band tightness, particularly the tensor fasciae lata tightness. The leg will react like a springboard since the leg remains abducted in mid-air.
Be happy. Look at me, I'm happy. Don't worry.
For hip scouring, patient lies supine while the examiner stands on the involved side and passively flexes and adducts the hip and knee. Examiner then applies downward pressure to femur while alternating adduction and internal rotation with adduction and external rotation of the hip. A positive is indicated by pain, apprehension of the subject, catching, grinding, or any unusual movements. A positive finding is indicative of a hip joint pathology such as arthritis, osteochondral defects, avascular necrosis, or acetabular labrum defects. For Craig's test, patient lies prone with affected leg at 90 degrees of flexion. Examiner stands on the involved side and palpates the greater trochanter. Examiner then internally and externally rotates the femur until the greater trochanter is parallel to the examining table. Patient then holds the position while the examiner measures the angle of the long axis of the lower leg and the perpendicular axis to the table with the goniometer. The stationary arm is perpendicular to the table while the fulcrum is placed over the patella. The movable arm is placed along the long axis of the lower leg. If angle is greater than 15 degrees, patient is positive for femoral anteversion. If measured angle is less than 8 degrees, femoral retroversion is indicated. Increased femoral anteversion leads to toeing in and squinting patella, while femoral retroversion leads to toeing out position.
Don't bring everybody down like this.
For the femoral nerve traction test, the subject lies on the uninvolved side with the hip and knee slightly flexed. The examiner places one hand on the lateral aspect of the subject's involved pelvis, while the other hand holds the involved lower leg. The subject then slightly flexes her head, while the examiner completely extends the subject's knee and extends the hip approximately 15 degrees. The examiner then flexes the subject's knee. The motion of hip extension and knee flexion places the femoral nerve on stretch. If the subject complains of pain along the anterior thigh, this may indicate decreased mobilization of the femoral nerve. For the piriformis test, the patient lies on the non-test side with the test leg in 60 degrees of hip flexion and relaxed knee flexion. The examiner stands with the proximal hand on the subject's pelvis and the distal hand on the subject's knee. With the subject's pelvis stabilized, apply an adduction force on the subject's knee. Tightness or pain at the hip and buttock area is indicative of piriformis tightness. Pain in the buttock and posterior thigh is indicative of sacroiliac impingement secondary to piriformis tightness. For the Eli's test, the subject lies prone. The examiner stands on one side of the table next to the subject's leg, placing one hand over the ipsilateral pelvic region. The examiner then passively flexes the subject's knee and notes the reaction at the hip joint. The test is repeated on the other side for comparison. If the hip also flexes when the knee is flexed, a tight rectus femoris is indicated.
She always saying we were meant to be. Somehow she thought I'd be.
For Trendelenburg's test, the subject stands on one lower extremity and remains in this position for approximately 10 seconds. Patient then switches legs while the examiner looks for a drop on the side of the unsupported pelvis. This drop indicates a weakness of the gluteus medius muscle on the supported side. For true leg length, patient lies supine while examiner measures most distal aspect of ASIS to most distal aspect of medial malleolus of the same side.
You should always test bilaterally.
A positive finding is a difference of more than 1 centimeter and is indicating a discrepancy in either the length of the femur, tibia, or in the angle of femoral neck inclination.
She doesn't want me around. She's got something.
For apparent leg length, subject lies supine while the examiner measures from the umbilicus to the most distal point of the medial malleolus.
You should always test bilaterally.
A positive finding is a difference of more than 1 centimeter, which is indicative of abnormal pelvic positioning. For Thomas test, patient starts standing and then is instructed to bring unaffected knee to chest and rock backwards. Once the patient is relaxed, the examiner checks the thigh for hip abduction and hip extension and lower leg for knee flexion. A lack of hip extension with knee flexion greater than 45 degrees is indicative of iliopsoas muscle tightness. Full hip extension with knee flexion less than 45 degrees is indicative of rectus femoris muscle tightness. Hip abduction external rotation during any of the previous scenarios is indicative of ITB tightness. Thanks for watching, and always remember to wash your hands after using the bathroom.